I'm glad you touched upon chemotherapy, because to me, chemo gets a really bad rap. But really, when you line up all the potential side effects of chemotherapy versus all the other new drugs people are getting excited about, is there really a difference in terms of number and severity? In other words, should we change the name of chemo to some other fancy name, drug name, and people won't think of it as chemo?
I think that, that it, if you interview my patients who get chemotherapy, the vast majority of the younger patients will tell you that the chemotherapy is cake compared to the hormone therapy. I mean, they'll just flat out tell you chemotherapy is nothing compared to hormone therapy. So number one, I agree that chemotherapy gets a bad rap. Chemotherapy was actually sold to me by Vladimir Hujek, who's at Minnesota Oncology up in Twin Cities. He told me that he can give chemotherapy safely. And the way I found out about it was I had a couple patients that I didn't have much to offer. They were in their 80s. They had advanced disease, and I shook their hand and said, I got nothing for you. And to my surprise, they came back 3 months later for follow-up. And they shake my hands and they say, thank you, thank you, thank you. I said, what happened to you? I got chemo. And I was shocked that chemotherapy, this was back before chemo was even part of our vocabulary. Back when, chemo doesn't work for prostate cancer and chemo is really lousy. These guys looked great and they had incredible responses. And so I started to realize that chemotherapy is much more palatable than the way people talk about it. And I think what's happened is as follows. In the olden days, when we had some of the chemo regimens, they were horrible and they did not work on prostate cancer. And I think that rap carried on to the newer generation now that we have Taxotere and so forth. So people talk like that, but the reality is Taxotere and Jevtana and these newer agents, much nicer and much more effective. And like you said, I mean, some of these oral drugs, they can be rough on the patient. Chronic fatigue, bone aches, pains, muscle pain, stiffness, changes in mentation. These are not innocuous drugs. And plus, in order to get the effectiveness of these drugs, you got to stay on them chronically. So it's kind of like, chemo, probably a little bit tougher or more stingy up front, but it's nowhere near as bad as it's being played out in the public eye. And in terms of benefit, I think it has a dramatic benefit for patients with advanced cancer.
No, that's well said. I think my pet peeve was when I talked to Dr. Dorff at City of Hope. My little rant was, in breast cancer, it's all laid out. You can look at how to prevent and how to treat all sorts of side effects from A to Z, and there's an expectation there of how to go after these side effects. I just have a feeling that that discussion doesn't occur as much with chemotherapy. I'll give you a case in point. Once in a while, a guy will call and he said, I want to tell my doctor that I don't want to lose my hair. How do I prevent hair loss, for example, but I'm scared to bring it up. In the breast cancer world, we've become very comfortable now bringing up that subject. And we have one type of chemotherapy, Jevtana, that doesn't cause that kind of loss. And I wish we could do something to encourage more of that kind of behavior.
When I talk to my patients, that's all part of the discussion. So we'll tell a patient you're going to get chemotherapy. These are the things that you have to guard against. You have to guard against neuropathy. You have to guard against low white blood cell counts. If you are, my practice has a lot of patients that CEOs, celebrities, things like this, they want to maintain their looks. So we have that as part of our conversation. We tell them you can go on Amazon, you can get a freezing cap so that you don't lose your hair. You can immerse your hands and feet in ice water to mitigate against the side effects of the neuropathy. So we already have incorporated that into part of our discussion. But there is a huge gap between how breast cancer is handled in the United States and prostate cancer is handled. And I don't fully understand that. I think it probably has something to do with the rugged individualism thing, where guys are not expected to talk about these little things or worry about these things, and where talking about illness is a sign of weakness, you know. But that's why I put that one slide up. When you look at death rates from prostate cancer, they're not that much lower than the death rates from breast cancer. So it kind of blows my mind that prostate cancer is not more organized and not more kind of heavy hand or kind of advertised as a serious illness in the United States, you know?
Yeah, I mean, hopefully we accelerate part of that. I just feel, I don't know what's relevant to each person. Is it their hair or they don't give a damn? But the reality is they should be allowed, they should feel comfortable having the conversation of what's important to them and will this drug affect that? And if it does, what's the plan?
I think that, when we talk to patients with about chemotherapy, first thing I say is it's not the way it used to be. I said, this is not the same kind of chemotherapy you give for lung cancer, pancreatic cancer, where, this is not, the final scene in Love Story or the final scene in, what was it, Brian's song, This is very treatable. And I also tell them very clearly, half the patients in the lobby, in my lobby, half the patients are getting chemo. You would not be able to tell. All right. So once they understand that, they feel, and a lot of my patients actually come back after their first cycles of chemo and they say, you know what? They said, I hardly experienced anything, and a lot of them will come back and say, however, the hormone therapy sucks so bad. Can you do this without hormone therapy? So chemo is actually very effective and not as bad as people kind of think it is,
Yeah, but you brought up a good point, and I know had an interest in this, that once you go on hormone therapy and you get castrate-resistant disease, for example, to get into a clinical trial, or when you're on chemotherapy, in a lot of these situations, you have to stay on androgen deprivation therapy. It's continuous. Even if you're no longer responding to it, you stay on it. Have we made any headway there? Have we determined that clearly staying on androgen deprivation therapy while you're receiving all these drugs for castrate-resistant prostate cancer is meaningful? Clearly is meaningful?
I was at one of these big round tables back a couple of years ago, and probably one of the smarter guys, Howie Shear, Memorial Sloan Kettering. He always cracks me up. So he was there, and we were all sitting there debating, why do we leave patients on hormone therapy? And so we were all staring at each other, and Howie Shear said, what I think is the truth. He said, I think we're scared to take them off hormone therapy. I mean, and to some extent, that is the honest answer. So when I think about taking a patient off hormone therapy, I always sit there and I think, are there cells that are suppressed by the hormone therapy that we haven't worried about for a long time that will suddenly rise up after we stop the hormone therapy? So that's my rationale for keeping them on hormone therapy, but we don't have the answer. We don't know.
Yeah. I wish we'd get the answer to that question. That's a tough one, because we say we have preliminary data that's positive, but it's preliminary, and I'm going, gosh, can't we get this answer? But I guess at another time. Okay, so I wanted to ask you about, since we talked about taking your testosterone away, you and I have never talked about this subject, and I don't even know if you have an opinion on it. At Hopkins and other places now, they're looking at a select group of patients with advanced disease who have failed a number of therapies, and they are giving them super physiologic doses of testosterone. It's called bipolar androgen therapy. They call it BAT. They had one trial, I think it was called Restore, RESTORE, or as a study. And they're saying that they're finding in some select cases, even while the person is androgen suppressed, if they give them a high amount of testosterone for a short period of time, that it may resensitize some of those cells that are no longer sensitive to testosterone. Do you have any comment on that, or is that just too preliminary?
I think it's very preliminary. I think that the original observation for high dose testosterone came out of France. And I think that it was tested in a fairly small clinical trial at Johns Hopkins, which showed some preliminary data that might have a utility for a subset of patients. But I think that the real cautionary part of this is, at least for me, because I've had patients that have failed that trial. And the cautionary part of this is, well, how big is the subset and what happens to those guys that do not benefit from the pulse?
Yeah.
So the problem with the pulse is that, yeah, maybe one or two guys may regress their cancer, but at the same time, one or two or more of those guys may have their cancer catch on fire and progress. So I think that you have to interpret the data very cautiously, and I'd be a lot more in favor of that study if there was some kind of indicator to pick out patients who are most likely to experience a favorable response to pulse therapy. Because if it's only going to happen for one or two guys out of 20 to 30 guys, then that's a dangerous situation. You know what I mean?
Absolutely. No, I call it I'm not saying that it equates to this, but I call it the lottery effect of prostate cancer treatment. The lottery effect is where, or you call it the Las Vegas effect. You go to Las Vegas, you see a picture of two happy people, Mr. and Mrs. Smith won $10,000 today, but you never see an advertisement that says, and we also had 10,000 losers during the same hour they won. So I call it the Las Vegas or lottery effect, and I'm always on the lookout. Is anybody doing that? I'm not saying they're doing it, but I'm saying it's an important thing to look at when you're looking at clinical trials.
I think that that's absolutely true. And that is exactly my concern with that particular trial.
Well, I appreciate your honesty on that. So it'll be interesting to see where that goes. Do you have every single patient now that comes to your clinic, or do you suggest that every single patient gets some sort of genetic study? Either on the tumor
we've really picked up on genetic testing. For our patients at first, we didn't really know how it fit in, but then we started picking up more and more that you do pick up BRCA gene mutations, you pick up downstream genes such as ATM or CHEK2 or so forth. And some of those things do in fact respond very well to PARP inhibitors. And some of the patients, believe it or not, respond to checkpoint inhibitors such as Opdivo, Keytruda. So for a lot of our patients, we do a fair amount of genetic testing. We usually do circulating tumor cells, and we don't look for pure germline. We look for acquired mutations.
Okay.
So they can be germline in nature, but they can be acquired during the treatment of the cancer. Yeah.
And are you doing multiple? Do you do multiple genetic tests on the somatic or acquired? I mean, so if someone stops responding to a certain therapy, then there's some cases where you do an additional genetic test because.
Oh yeah, we will repeat after every kind of section with a systemic therapy. So Taxotere, after that we'll repeat if there's recurrence. Yep.
That's interesting. That's really, really interesting. Now let me just kind of finish up with two other thoughts. This lutetium PSMA 617, this radioligand.
Yep.
So they reported this overall survival benefit that was significant. Radiographic PFS, progression-free survival, significant. It met both primary endpoints. It was called the VISION trial. You sent people, like you said, to the VISION trial. But here's something I found interesting, and I think this is what you were alluding to, and tell me if it was or it's not. Actually, ideally you want to get a PSMA scan and it says, okay, you're a good candidate for this, and then you get lutetium when it gets approved. But it said 87% of those treated had positive PSMA scans. That's not 100%. So does that mean that some people who don't have a positive PSMA scan could possibly respond to this?
I don't really know what that line is referring to. So I can't clarify that particular line if it's written like that. I'm wondering if it was meant to read that out of 100% of patients that tried to get on study 87% had positive, whereas 13% did not have positive scans and did not qualify for treatment.
It could have, but is it possible to there? I know that there is some discussion, regardless of that statistic, of, do you have to show a heavy amount of PSMA? Do you have to light up a lot in order to qualify?
Right now, the VISION trial is really powered just to get that modality of treatment out there and approved, which I think it should be approved. The nuances about who's going to be a big responder, who's going to do better, all of that, that's still up in the air. That's going to take further trials. There are a million things we don't understand. Some guys light up real heavily with PSMA. You give them lutetium, it don't work at all. Other guys, they have a little bit, it works great.
Huh.
It's just like everything else. I think that we're going to spend another decade trying to tease out all of the things. How is it working? Why is it working? Why doesn't it work? So forth and so on,
Yeah. But I mean, when I talked to you before, you seem pretty excited about this finding, and we're assuming this is the next FDA approved drug in prostate cancer, right?
I think so. Yeah, I do.
I think that's really exciting. Last point, this ditty I pulled out from the JAMA Network Open. This was a collaborative effort done by a number of institutions. This looked at the primary cause of death in metastatic prostate cancer patients from 2000 to 2016. Let me read you the conclusion when they looked at over 26,000 US men.
Mm-hmm.
And this was just published on August 5th, 2021. In this cohort study, deaths from non-cancer causes, including cardiovascular disease, these are metastatic patients, constituted a substantial number of deaths among men with metastatic prostate cancer. AKA, they argued that there's so much we still don't even know about metastatic prostate cancer that a lot of men are dying from other diseases, including that not prostate cancer or another cancer. And they're saying that there's so many still dying of heart disease that maybe a number of these patients should ask to have a cardiologist if they have a high risk for cardiovascular disease. I mean, do you see this when you're talking about metastatic disease? I know this is a lethal and a terrible disease for many men, but what this opened up the door was, hey, a lot of men do fine during treatment. It's the other things that also come up and get them potentially that we're not looking out for. Do you have any comment about that?
That's believable. I mean, I think that if you just focus down on the cancer and if you drive real hard to treat it, I think that patients can get in trouble from other aspects of their well-being, their heart conditions, their minds, so forth and so on. I am a fairly strong believer that to some extent patients do have to take somewhat holistic approach to managing their cancer. There's no question. Good diet, good exercise, good weight control. And if they aren't doing it, things aren't going to go well. I try to tell my patients that all the time.
Yeah. No, it just gets very interesting because it's also what you said that I think it's a testament too to, oligometastatic disease is still called metastatic disease, right?
Right. Absolutely.
And so, I mean, that counts as someone with metastasis. And so it just seems so intuitive. It seems so logical that if you really believe that they're not going to succumb to this and you can keep it under control, wouldn't you want to take care of the other things that might come at them that they're high risk for?
Absolutely. Absolutely. No question.
So, we're going to move to part 4 and for a later time, but you promised me when we first talked to get you here, there's 2 things I wanted to tell you. You're always so good at teaching all of us something, the audience, myself, the group, that if Mayo Clinic had a football team, I think you'd be the head coach. It'd be head coach Kwon of the Mayo Clinic team, because to me, there's 2 things when I associate Mayo that are very famous with me and very popular. Look at all these little extras I have. There's mayonnaise, right? But then there's also Dr. Kwon at Mayo. So I'm really appreciative of all this knowledge. I know you'll never have a football team because you guys are mostly brain talent, not necessarily athletic talent, but the truth is, I mean, you guys do such a good job teaching, but you promised me you would not leave this 3-hour session without showing me your guitar skills or some version of it.
And I got this through security here at Mayo Clinic, and this probably violates just about everything in terms of security.
I don't want you to worry. No one's watching, and except the 10,000 plus that watch your videos on an average basis.
Great. So are you familiar with a guy named Elvis?
Thank you. Thank you very much. Absolutely.
You know, the song Falling in Love, right? Wise men say that only fools rush in, but I can't help falling in love with Mark Moyad. So actually, that's not the message I wanted to get out there.
I think I like that message.
But I do want this message. So I was working on this.
Okay. I like the first message, though.
Yeah. It's the same song. Actually, I only know one song. I'm a urologist. What do you expect?
That's okay.
Moyad say, check your PSA. But Mark Scholes said, get a pet instead. How's that? It's a little ditty I made for you, huh?
Hey, Kwon is in the building. Kwon is in the building.
All right.
That's just beautiful. I love it. So I just want to say, I'm not going to try to get too gushy here, but sometimes I take it for granted. You know, we get to play. I get to play in the NFL, meaning I get to interview and pass information back and forth with some of the top people. And you're definitely at the top. And it's always such a privilege and a pleasure. And I just appreciate you. I appreciate what you do for us and everybody else. So I'd love to. I wish I could say it for 2 hours, but you know how much I mean it off camera. Thank you. Thanks for everything you do, Eugene. I really appreciate it.
It's my honor and privilege. It really is. This is just my way of putting good karma back in the world. You know, we need a lot more of that, right?
No, I agree. I appreciate that. And please tell your parents I said hi, and tell them that I understand what they mean when they say that you should have gone to Harvard. I
thought you were going to say when they said that I have no musical talent. That's
the audience right. Didn't. I didn't want to reveal that, but the audience didn't hear that part. That your parents basically said, "Stick to your day job."
Yeah, and actually, to be honest with you, I hand CDs to my patients, and some of them come back. I was always surprised that my patients would be willing to say this, but they'll come back and they say, "Yeah, doc, I don't think you should give up your day job."
Well, I just get the feeling that you could be Elvis. You could be really good, and people would still say, "Don't give up your day job," because what you're doing is changing people. I mean, you're completely changing the trajectory of their lives for the better. So I think you're in a rough spot. It doesn't matter how talented you are vocally or guitar wise. It's never going to surpass what you're doing day in and day out at the Mayo Clinic. So thanks again. Like I said, I don't want to turn it into an Academy Award-winning speech or a Barbara Walters interview where I just start crying the whole time. But I'll see you in the after show. And thanks for being you. I appreciate you, man.
Thank you so much.